Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Dr. Anwar Saeed, welcome to the Healthcare Unfiltered Express. Thank you so much for joining me.
Thanks so much for the invitation, Chadi. My pleasure to be here.
And congratulations on a wonderful ESMO that you actually had. Great presentation that I listened to, and congratulations on the publications and all of the success. So with that, let's you come on the podcast to share with us what you presented and what the paper was about. And then I've asked you to kindly put that information and the data that you have in context of the broader disease spectrum and so on. So let's start with the data that you presented on the podium and the paper that was published at the same time.
Yeah, thank you, Chadi. Thanks again. So to present, first of all, give a background on the trial. So I presented the results of the Stellar 303 trial, which is a pivotal phase 3 trial that looked at the combination of zanzalintinib and atezolizumab versus regorafenib. It was a global phase 3 trial that enrolled 901 patients. And so to give a background, the idea of combining VEGF tyrosine kinase inhibitor with immune checkpoint inhibitor has been explored in a number of early phase trials across the last few years in this particular disease, in the chemorefractory colorectal cancer setting. And there has been a variation in terms of outcome, but a trial that I've done called Camilla trial that combined the parent drug of zanzalintinib called cabozantinib, and it's a multi-VEGF MET tyrosine kinase inhibitor with similar tyrosine targets to zanzalintinib. That was combining cabozantinib with durvalumab, a PD-1 inhibitor, in the Camilla trial. So one of the cohorts in that study looked at the chemorefractory colorectal cancer population. And we have seen impressive responses in this population. And I was actually very impressed with the outcome because when I did the study, it was based on good rationale and, kind of a translational science from preclinical studies that showed synergy when you combine both in multiple diseases. And so we explored it clinically as a phase 1/2 study. And seeing those responses and I would say good stability of the disease and good survival outcome triggered, the next step. Because, when you see this as a GI oncologist, the first thing is like, we know immunotherapy do not typically work in microsatellite stable colorectal cancer. And so seeing those responses really encouraged us to move to the next step. And in line or in parallel to this, zanzalintinib, we also explored zanzalintinib in combination with atezolizumab in an early phase basket study in the colorectal cancer cohort in that study, where we looked at zanzalintinib atezo versus zanzalintinib, not a powered randomization, but a parallel phase 2 study, showed encouraging signal with the combination as well. So those are the early phase 1/2 data that supported the launch of the phase 3 Stellar 303 study. And so in this study, we have seen the primary endpoint of the study was an overall survival in the intention to treat population, as well as overall survival in patients who do not have liver metastases. So the study, to make an important message here, is that it is tailored purely to patients who are microsatellite stable. So we have to have a documentation before the patients enrolled on the study that they have a tumor that's not MSI high and not mismatch repair deficient. And so I presented the final data for the overall survival.
Say that again. Let's just hold on this again. These patients, they needed to. You looked at the microsatellite status of these patients as part of the inclusion criteria?
Yes, we have to have a documentation. So as part of eligibility criteria, the patient should have a tumor that has a documentation confirming that it's not MSI high and not mismatch repair deficient. So we're looking at, the mismatch repair proteins with IHC or PCR results for MSI.
Got it.
So, so we're kind of tailored purely to the microsatellite stable population. And at the ESMO meeting, I presented the overall survival, the final results for the overall survival in the intention to treat population. And I also presented the interim analysis of overall survival in the subgroup of patients without liver metastasis. So the study continues, and in a future meeting and publication, we will present the final overall survival in patients who do not have liver metastasis. So as far as OS in the intention to treat population, that's final data, and it showed a 20% reduction in the risk of death with hazard ratio of 0.8, and median overall survival 10.9 months in the combination group and 9.4 months in the regorafenib group. And we have done subgroup analysis as far as forest plot, as you've seen in the in the slides from the ESMO meeting. We've shown a consistent benefit. It's actually very impressive because when you look at phase 3 trials, typically you see in the forest plot, typically you'll see subgroups where the control arm is doing better. And if you look at the forest plot from Stellar 303, almost every group is showing benefit toward the combination as opposed to regorafenib. And that's kind of striking because when we built this study, we built it with a rationale, and particularly if you look at the design, that we have a dual primary endpoint looking at also patients who do not have liver metastasis. We did it with the background thinking that immunotherapy might work in microsatellite stable disease and might be tailored to certain subgroups. And given the previous data from subgroups in the LEAP study and other trials, we're thinking that it may be tailored to patients who do not have liver metastasis, or maybe tailored to patients who have RAS wild type based on the Camilla trial data. But, it was striking. When you look at the forest plot, the subgroups, there are certain, median survivals maybe slightly better in certain subgroups, but there's a consistent benefit favoring the combination and all those
But you're saying that for the subsequent analysis, we'll look specifically at the liver metastases.
At the patients who do not have liver metastasis.
Who do not have liver metastases. So, I mean, I guess, is the trial powered that the subset analyses for these patients could detect something versus not?
Yes, it's a dual primary endpoint.
Yeah. Okay.
So we have a two primary endpoint. One of them is overall survival in the intention to treat population.
And the other one is the ones without the liver metastasis.
That's the one I presented. Yeah. And then we have another primary endpoint for the study, which is it's a primary endpoint, and so it's powered statistically. And that primary endpoint is looking at overall survival in patients who do not have liver metastasis. So that will take time. Hopefully, we'll present it sometime next year. But those patients live longer, and as you see in the interim analysis, it showed also a wider delta.
Right. It's fair to say that this is, I mean, is this a new standard of care?
To me, looking at the fact that it's, I would say, rigorous phase 3 global study, very, using, very strong statistics. I mean, it showed us, it validated what we've seen in early phase trials. The median overall survival is in line with what you've seen with the combination in early phase trials, whether you say Camilla trial or other trials that examined either zanzalintinib or cabozantinib. And so I feel like it's a phase 3 validation. And it is expected that the delta will not be very deep in an intention to treat population, but there will be subgroups with deeper delta. And I expect the patients who do not have liver metastasis, the patients who have RAS wild type, are benefiting the most from immunotherapy. And I think that's also supported by, there's a lot of preclinical and translational data showing that the tumor microenvironment for patients who do not have liver metastasis are very immune permissive compared to patients who have liver metastasis. And also the tumor microenvironment of the RAS wild type population are more immune permissive than the RAS mutant tumor microenvironment. And so this is in line with how those subgroups behave to immunotherapy regimens.
Yeah. And the data is already published.
Yes, it's published in the Lancet. So we were very thrilled that the Lancet accepted the paper. And
Not too shabby, the Lancet, not bad. Congratulations. This is really great. So Anwar, help me understand with this information though, put it in a larger context into how does the field now of metastatic colorectal cancer is in terms of therapy or prognosis post ESMO 2025 and considering what you presented?
So I think there has been a lot of so at the GI cancer space, there's a number of organs, right? So upper GI, colorectal cancer, and then there's HCC as well, and so there has been a lot of, in my opinion, impactful trials that was presented at the meeting and gave us a hint of where the field is going, and I believe within the colorectal cancer space. And I might be biased, but I think Stellar 303 has the most influence in terms of moving the field. It's probably the only one of the only practice-changing trials presented. And to me, the influence is not just because it's practice-changing. It is the first phase 3 trial to show and the impact of immunotherapy-based regimen in patients with metastatic colorectal cancer that's microsatellite stable. We have seen multiple data combining variation of immunotherapy regimens, whether immunotherapy as monotherapy regimen or doublets, and there will be a multitude of other trials combining with either CTLA-4 inhibitor or other immune modulators that will likely show some benefit in patients with MSI high, but not MSS. And so seeing the first, practice-changing study that's positive in the microsatellite stable population, I think this is very, very impactful. And yes, the delta is not deep, but I think it's the door, it's the beginning of a new era that will enable us to explore immune checkpoint inhibitor as a backbone or in combination with other immune modulators and other maybe chemotherapeutic agents or VEGF targeted therapy or bispecific T cell engagers in this group of patients down the road that we're going to see likely within the next few years.
I have a couple of questions for you. One is regorafenib. Is it now going to be reserved for last thing, or do you think there's really no role for it at this point?
In my opinion, it's I will say it's a solid drug.
Yeah.
It's a solid drug. The first VEGF TKI approved in patients with colorectal cancer. And it has shown itself, just like sorafenib in HCC, it's hard to beat. Multiple trials that came after regorafenib that failed to beat regorafenib. I mean, the LEAP phase 3 trial, the LEAP phase 2 study, named them. Multiple trials that was presented over the last few years that failed to beat regorafenib or sorafenib or Lonsurf. But to me, it's a solid drug. Will I use it in clinic? I think if I have a patient who do not have any contraindications to immunotherapy or VEGF targeted therapy, I would rather use a combination.
Right.
And I could easily adjust the doses of what I have as far as the TKI molecule to a level of tolerance. Yeah. We have learned it across the years of that the TKI using the pill the dosage could be adjusted. We have to keep in mind that Stellar 303 took zanzalintinib to phase 3. This is the first phase 3 with zanzalintinib ever. And so we probably used a higher dose than the dosage that's effective and what we say happy medium. And I feel like with time, with experience, there will be a real world analysis that will create a redose, just like how regorafenib redose was tested after regorafenib approval based on the correct study.
Right. It's not going to be clear also whether regorafenib will have activity after failing the combination regimen.
Probably no.
Right?
I would not use regorafenib post failing the combination, but I would probably use it in someone who have contraindication to
Contraindication.
immunotherapy.
Okay. My last question to you is this regimen being explored earlier in the disease in microsatellite stable? Are there any thoughts to bring this earlier from metastatic disease to earlier courses? Or even earlier in metastatic disease?
I think we are encouraged by the signal, and I think the signal actually gives us a hint that if you have a combination that works in a chemorefractory population in a global setting, that means it will likely work if you take it earlier, either in the earlier, I would say, lines of therapy in patients who have unresectable stage 4 disease, or earlier stages of the disease as well. I see a window of opportunity exploration, for example, in an MRD setting. It could also be in combination with either chemotherapeutics in the peri-op space, but particularly as well in the neoadjuvant space, because we're seeing more and more microsatellite stable trials showing some impact in the neoadjuvant space. And I think out of ESMO, Dr. Shalabi team presented their findings from the niche trial in microsatellite stable colorectal cancer. It was also published simultaneously in Nature, and showed really impactful signal using immunotherapy in the neoadjuvant space in colon cancer. So to me, that's another very impactful study that was at ESMO, and also another hint to tell us it's time to move immunotherapy in microsatellite stable. We have two hints in the early stage setting and later stage setting.
Yeah. It is interesting because we've always been taught for years back that, the MSI high are the ones that respond to IO. So I do think it was pretty revealing to see the activity of IO therapy in MSS disease.
I mean, I'm very thrilled because I witnessed it with hands-on experience. I have patients who went on Camilla trial back in 2019, and some of them may have survived up until 2025.
Yeah, amazing.
We have never seen this. You can't see this with regorafenib.
Yeah. Anything else before I let you go, Anwar?
Thank you. Thank you for having me again, and my pleasure. And thanks so much, Charlie.
Congratulations on all of the success, and we'll have you back again for a little bit more of a broader discussion after ASCO GI, so get ready.
Appreciate it.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.